first day he was not able to take the liquids as well because he has severe abdominal pain as well
No, my
and
question
vomiting.
is, when you were planning the diet, what is the first thing that you thought should be most important? What is the first thing? Was it the calories? Was it the proteins? Was it low residue? Was it weight gain? What is the main thing that you were looking at?
I was aiming for the healthy weight gain, ma'am.
Okay. All right. Because he
And
was,
yeah, ma'am. And apart from that, his BMI was normal. The thing is, at least during the hospital stay, I aimed like there should be no weight loss. At least he has to maintain the weight from the admission to the discharge. That was my core objective.
yes, good. Thank you.
Sarika?
Yes, ma'am.
Yeah. So, very good presentation. So,
Thank
I
you,
just
ma'am.
have two questions for you. Like in the clear liquid diet, you have mentioned buttermilk. So, I wanted to know, is buttermilk, does it come in the in clear liquid? Like,
Yes, ma'am. Actually, we have made in a thick consistency and we have supplemented to the patient.
also means thinner consistency. Like,
Yes,
Yeah.
ma'am. Thinner consistency.
thinner consistency. And I just wanted to know, like, to which economic strata he belonged, because you have given him peptide-based ONS, and plus you have given him the other this soy and the other this in the diet also you have given him many things. So I wanted to
Yes,
know
ma'am.
which economic strata he was from.
He was coming under a middle class family only, ma'am.
Okay, so it means this the supplement was he given at a means through a government this, or what was it like, or was he paying for it?
Yes, ma'am. Actually, few of the supplements we have been supplemented from our side as well as
Okay,
seeing his poor economic status as well, ma'am.
okay. So you all were supplementing it.
Yes, ma'am.
Okay, okay. Thank you.
Okay, Sarika, excellent presentation. I really like the details in which you have gone through. Okay,
Thank you.
and can you just elaborate on the assessment and the screening tool that you have used?
Yes, ma'am.
And
We
how
have,
did you go ahead with it?
ma'am.
How did you go ahead with the screening and the assessment tool?
Yes, ma'am.
What are the
We have actually screened the patient with subjective global assessment, ma'am, where we have taken his 24-hour dietary recall. Apart from that, how was his food intake previously since 3 weeks or 3 months or 6 months, and any history of weight loss was seen. Apart from that, how there his mobility and functional capacity as well, and how was his food intake, and any gastro related symptoms persist or not. We also looked into that.
Okay, so what was the difference? What did you actually see on the assessment? What is the things which you have seen which made you feel that the patient was malnourished?
Yes, ma'am. He came under a score of mild to moderately malnourished. So,
Okay.
as he has a Crohn's disease, which comes under score 1, when we score with the disease severity, and apart from that, his oral intake decreased since 1 month, ma'am, because of the gastro symptoms as well. So there was
Okay.
only a 5 kgs of weight loss. Like that doesn't there was no such severity of weight loss was seen, but as he was coming under score 2 of disease severity, and apart from that, one considering the last month oral intake and his gastro symptoms, we have been screened him. Apart from that, his albumin levels were also low, ma'am. So that is also one of the assessment where we re-screen the patient looking into the parameters as well and considering the WBC count as well.
Okay. So in this case study, what were your major challenges after because counseling a patient from the admission to the discharge is a big challenge when when a dietitian plays a role, right? You will
Yes, ma'am.
agree to me. So what are your challenges and how did you overcome that?
During hospital stay was not a major issue, ma'am, but for them to come up for the follow-ups was little difficult, where within the one and the second week I have to call them, and I was like, just please come for the follow-up. like where we can actually rescreen your nutritional status and improve accordingly. So that was really challenging during the follow-ups, ma'am.
Okay, good. Thank you, Sarika. It was
Thank you.
really nice. It was really
Thank you.
nice.
Thank you.
Yeah, bye.
All right. Thank you, Sarika.
Thank
Very
you.
good presentation. And our next presenter is Tejasvi. Are you ready?
Yes, ma'am, I'm ready.
Okay. Sai, can you please share her presentation? Okay. So Tejasvi, your time starts now. You have 10 minutes to do your presentation, and then you'll have 2 minutes for the question and answer. Please stick to your time, and we will remind you when it is a
Sure, ma'am.
minute.
Thank you. Yeah, can I start, ma'am?
Yeah, please go ahead. Your time starts
Okay.
now.
So, warm good afternoon to everyone. I'm dietitian Tejasvi from Yashoda Hospitals, Malikpet. And today I'm going to present one of my case studies, that is TENS, which is abbreviated as toxic epidermal necrolysis. It is a next slide. Excuse me, next slide, please. Next slide. Yeah, it is a severe life-threatening dermatological disorder where we can see erythema, necrosis, and bullous detachment, and also to the epidermis and mucous membranes, resulting in exfoliation. And in severe cases, it can lead to sepsis or even to death. And the major causes include drug implications. This case, we can see few in a million people, and it can affect all the age groups and races. It is slightly more common in females when compared with the males. It is 100 times more common in association with the HIV or some retroviral diseases. And my patient, he's a male patient, who's 65-year-old male patient. His BMI was 24.5, which is considered as overweight as per Asian BMI classification. His final medical diagnosis was a toxic epidermal necrolysis, and he's also a known case of CKD, post PTC and Parkinson's disease with comobs like diabetes and hypertension. And the reason for his admission was hypothermia and erythematous rashes, which is nothing but red kind of patches on the skin overall the body, and severe itching at the same time. And he's also having severe mucosal oral mucosal ulcerations, and he has also episodes of diarrhea where he used probiotics prior to the hospital admission, which made the condition even severe, like that developed rashes and bullous lesions all over the body. Bullous lesions, which is nothing but fluid filled bubbles kind of lesions all over the body. And here the present complaints was erythematous rashes and oral mucosal lesions. Next slide, please. And the patient is having comorbidities like hypertension and diabetes. My patient was treated with antibiotics, corticosteroids, decarboxylase inhibitors, statins, calcium channel blockers, anti-allergics, and intermediate insulin, nutritional supplements, and benzodiazepines, antacids, and essential amino acid blend solution. Diagnosis test was done of histopathology biopsy, where it revealed that the patient has TENS condition. Generally, SGS and TENS are differentiated based on this body surface area. If it is less than or equal to 10%, it is considered as SGS, which is nothing but Steven-Johnson syndrome, as the patient body maximum covered, which is of 30 or more than 30%, which is considered as toxic epidermal necrolysis. And clinical course timeline, the patient has a chronic pain assessed with basis of Scott and score. Here, initiation in the ICU stay was educated about the nutrition intervention, the patient and their attenders, and follow-up was done. Where gradual reduction in pain score, improved functional ability, and adjustments were done with both macro and micronutrients, electrolyte management, modified as per his requirement, and outcomes was good pain control was seen, and no adverse effects, and continued MNT as per advice. And these are his other biochemical parameters, like he was having hypoalbuminemia, anemic, and creatine was a little bit higher on the initial days of admission, but was normal when the patient got discharged. And blood urea and nitrogen was were still on the higher sides. Electrolytes were normal while discharged. Next slide, please. And coming to his nutritional assessment, these are the anthropometric measurements of my patient. And coming to his nutritional intake, as per his 24-hour dietary recall, he was only meeting around 768 calories and 27.4 grams of protein through his oral intakes. And functional markers, we included hand grip strength, which gives score of 15, and mobility was nil. And coming to nutritional screening and diagnosis tools used, we used SG and NRS 2002, where score revealed 1 to 2, which is moderate risk for malnutrition. Next slide, please. And coming to the nutritional diagnosis, PET statement, problem, etiology, and symptoms. Problem includes itching, overall body, erythematous rashes, diarrhea, anemia, and overweight, hypoalbuminemia. Etiology includes irregular meal timings, overexposure to sunlight, overuse of antibiotics, prebiotics, and weaker immunity system, and inadequate fluid intake, that is dehydration, and drug and nutrient interaction. And coming to the symptoms, pale colored hair, nails, and severe itching all over body, and hypothermia. Next slide, please. And coming to the nutrition intervention goals, both the short-term and long-term goals. Coming to short-term goals, it includes like minimizing the metabolic stress response and to retain and maintain fluid balance and to promote the rapid recovery and wound healing in view of nutrition intervention and minimizing the risk of complications and sepsis and to attain normal nutritional status and lean body mass overall the hospital stay. And long-term goals includes to attain the adequate nutrition post-discharge with a high-protein renal diet till the recovery is maximized, and to meet the daily requirements, that is RDA, as hypermetabolic state exists for a very longer periods, as this case is very severe to burns. Once when the patient will be fully healed, then we can follow minimal protein diet because he is a known case of CKD, and to be followed by the dietitian for every 2 to 3 months, at least for an year. Next slide, please. And coming to the micronutrient supplement, fluid and electrolyte strategies, the table, the micronutrients needed for this condition include vitamin C, vitamin B9, iron, copper, selenium, and zinc would fall into the first category, the major micronutrients. And fluid electrolyte balance include amino 1 10% is a amino acid, essential amino acid basis solution, which is of 500 ml volume, which gives 200 kilocalories and 50 grams of protein. We have given 2 bottles of such during his hospital ICU stay. And electrolyte balance will also be covered in this. And fluid resuscitation includes around 60 ml per kg ideal body weight, that is around 4,000 ml per day can be given, or even more in some severe critical conditions. And coming to his RDA, these is the RDA that I have given to my patient. Yeah, next slide, please. And monitoring and evaluation. Coming to the weight trends, my patient, he has not weighed much of my patient, he didn't lost much of weight, just the extra weight is lost, that is of which is of duty edema. And in intakes adequacy, coming to intakes adequacy, as my patient is already having severe mucosal ulcerations, but still he tried to maintain the oral intakes rather than going with the RT feeds. He was really supported us in view of nutrition intervention. He started with oral diet, which is of high protein renal diabetic soft diet. And on the initial days, for the first 2 to 3 days, his index was around 33.3%, which gives 566 kilocalories and 20 grams of protein from our hospital diet. And later he was able to meet around 50%, then followed by 70% at the time of discharge all over, and which served 1275 kilocalories and 45 grams of protein from the oral diet. And coming to the wound healing, his skin shedded and started recovering, where might slight scaly tissues and small spots or rashes kind of things are visible on his lower limbs. And coming to his labs parameters, most of his parameters like electrolytes were on the normal ranges when he was getting discharged, but the creatine and albumin HB was slightly in abnormal ranges. And his length of stay was 15 days. Length of hospital stay was 15 days, and targets met on an average compared with the whole hospital stay. Calculated when we have calculated the overall hospital stay, he met around 60% of his RDA during the time of discharge, where we supplemented with appropriate polymeric ONS alongside some protein such as 4 per day. Next slide, please. Next slide, please. And coming to the recommendations, moreover, we in such cases we should prefer more of micronutrients such as vitamin C, B9, iron, copper, selenium, zinc, which I have already mentioned, and fluid resuscitation also I have mentioned in the previous slides. And diet should be more in complex or variety in forms, which should where we can include food from the all the food groups, and regular meal timings to be followed along with the medication timings, and always enteral nutrition to be preferred. In case of if any is contraindicated or any abdominal compartment syndrome is seen, then TPN can be indicated. And increased all the macronutrient needs are definitely increased, and proteins around of 20 to 25% of total energy intake of proteins, and carbs from 60% from total energy intake, and fats 12 to 15% from total energy intake can be considered for such kind of patients. And coming to the follow-up, I have done 3 follow-ups for the patient: the first within 10 days, second within a month, and third within 2 months. And when coming to the third follow-up, the patient the response was also very good, but it was a little bit hectic. But I have taken, even though, since when I came for the third follow-up, the patient was able to meet around oral intakes of 75 to 80%, and 70% of his scars on the skin got recovered, and a majority of his parameters was also maintaining on the normal range, except this creatine.
Tejasvi,
Ma'am.
time up, please. Finish up
Oh,
as soon as you can. Okay.
yeah, so okay, ma'am, sure, sure. And the challenges faced was, as the patient was having a known case of CKD, and along also oral mucosal ulcerations, just to contraindicate, I mean, to avoid the RT feeds, and the patient was also supporting at the same time. It was really a big challenge in this kind of conditions, and also to match his RDA and to maintain his lab values normal. Uh, Kind of tough time for planning a appropriate diet for this patient, and things worked well. The patient was able to tolerate the oral diet along with the appropriate ONS very well. And next slide, please. Next slide, please.
Sai, can you change her slide?
And coming to the summary, it is a early nutrition intervention in such kind of cases are really a very big challenging thing, and it should be mandatory also at the same time. And protocols, we used all the ICU protocols as per the guidelines. The initial assessment of nutrition was done within 24 hours, and oral diet was started within 48 hours. And the feeding was adjusted as per patient's convenience, and a standard calorie and protein intake measurement was set at the initial time of the assessment. And both the micronutrients and fluid resuscitation and monitoring chart was also given to uh, the nursing staff as per the protocol. And first follow-up, the patient intakes was around 70% of his RDA. And coming to the multidisciplinary team approach, where the doctors like physicians, plastic surgeons, and dietitians involvement at the same time, pharmacists, nurses, and physiotherapists, everyone's involvement helped the patient to get into a early recovery, and the final outcome was faster healing, fewer complications, and improved survival. Thank you.
Okay. Thank you so much, Tejasvi, for that.
Yeah, thank you, ma'am.
All right. Let's see if jury members have any questions.
Um, can I go ahead?
Yeah, please do. Ananya.
Yeah. Hi, Tejasvi. Tejasvi, can you hear me?
Yeah, yes, ma'am, I can hear you, ma'am. Good
Okay.
afternoon,
Again,
ma'am.
a very nice presentation. Only the thing which I think your presentation lacked was the, you didn't give us the diet plan at the time of discharge, and how much was the
Mm,
patient's intake, and how did you go ahead with the hospital diet. And that's what I would have loved to see, because the
definitely.
presentation was, the case itself was so interesting. You could have, that
Yes,
one
ma'am.
touch was what it's actually missing.
Yeah, I got it, ma'am, but I wanted my presentation to be short and crisp, but it's okay. I got you, ma'am. Yeah, thank
Yeah,
you.
but yeah, these are the vital things which we should when we present our case studies, is the ones which we have to really look into it.
Sure, ma'am. Next time I consider this for sure. Yes.
Yeah, and for maintaining high protein for your patient,
Yes, ma'am.
what did you do for giving a high protein diet to your patients?
Yeah, as we already know that my patient is a known case of CKD, but still we have to go with the high protein for this condition. So I have provided high biological value proteins in his diet as he was able to tolerate orally. At the same time, some protein-rich polymeric supplement was given along with protein sachets, four given, which gives 20 grams of protein. At the same time, amino and amino acid, essential amino acid based blended solution was given him via IV. So that also gives 50 grams of protein for each bottle. So overall, he was able to meet his RDA in view of protein, ma'am. Not like up
Thank,
to the mark, but around 60 to 70% he was able to meet by the time of discharge from our hospital side, ma'am.
thank you, Tejasvi. All the
Yeah,
best.
thank you, ma'am.
So Tejasvi, for next time, you can have the slide for the diet, but you can just skip through it with the time.
Yeah, ma'am. Sure. Thank you. Yeah.
All right. So we are going to just move on to our next presenter in the interest of time. Sai, are we ready with the presentation for our next presenter?
Yes, ma'am.
Madhavi, are you ready?
Yeah, ma'am.
Okay, great. Please share the screen, Sai. Madhavi, again, your time is 10 minutes. Please stick to it. Make sure
Okay,
that
ma'am.
you're wrapping everything up within your time limit.
Yeah, ma'am.
All right?
Good evening,
Thank
all.
you.
I'm Madhavi, dietitian from Ozone Hospitals from Hyderabad, and today I'm presenting this next slide. Jaundice and CLD patient. Introduction: Jaundice is characterized by yellow discoloration of the skin and sclera due to elevated serum bilirubin levels. In chronic liver disease, CLE impaired hepatic function significantly affect bilirubin metabolism and nutritional status. Target was nutrition therapy plays a key role in supporting liver function and preventing complications. Next slide. And the case study, my patient was 41 years old patient with BMI 28 point kg by meter square. It is her overweight, and my patient is non-vegetarian, and he is diagnosed with chronic liver disease and portal hypertension and esophageal varices. The patient was admitted for evaluation and management and discharged in stable condition. Next slide. And nutritional assessment, biochemical findings, laboratory investigation. My patient was high in bilirubin levels 9.5 and SGO2 185 and SGPT 46 and ALP 196. Serum albumin level is 3.4, slightly low. And renal profile and electrolytes are normal. Next slide. Nutrition diagnosis: impaired liver function with risk of protein energy imbalance related to chronic liver disease and hyperbilirubinemia. And next slide. Nutrition interventional goals: an individualized diet plan was prescribed, providing 1605 kilocalories in a day with high carbohydrates intake 208 grams per day, adequate protein 85 grams, and low salt 35.7 grams in a day. Small frequent meals were advised to improve tolerance and reduce hepatic load. And key nutrition strategies: high carbohydrate intake to prevent protein breakdown, adequate high biological value protein, low fat diet to reduce hepatic load, and small frequent meals to improve tolerance, vitamins and minerals rich foods. Next slide. Dietary recommendation: dieting foods recommend to the patient. The patient was orally stable, and the bilirubin levels are high, but the patient orally taking good. That's why I suggest a bland diet to the patient. with low salt and low spices. After the patient was admitted in 3rd May, and he was discharged 5th May. The bilirubin levels are stable, and I recommended when the patient was admitted soft diet, like soft khichdi and dalia, like that. In second day, I changed my diet. Why? Because the patient gut also good, and his bilirubin levels are slightly come down. While discharged, I advised jaundice diet, and I told them to avoid fatty foods and like high fat curds, high fat milk, and high fried items, like that. And dietary recommendation: diet include whole grains, fruits, vegetables, leans, protein sources such as dal, eggs, fish, and adequate fluids. Fried foods, alcohols, red meats, processed foods, and high sugar items were avoided. Next slide. Outcome: following nutrition intervention, the patient reported improved appetite and tolerance to oral intake, clinical condition stable, and the patient was discharged with dietary counseling for continued liver support. Next slide. Seventh slide is missing. This case highlights the importance of structured nutrition therapy in the management of jaundice associated with chronic liver disease. Appropriate macronutrients distribution and patient-specific dietary counseling contributed to clinical stabilization. Next slide. Thank you. I'm sorry, some slides are missing.
No worries, Madhvi. That was good effort. Jury members, do you have any questions?
Yeah, I have a question. I don't see anything related to the diet plan here. What is the clinical assessment done, nutrition assessment? What kind of tool was used, and what was the 24-hour recall done, and what was the nutrition intervention? So
Yeah, ma'am.
just had a
Patient
question on
was
that.
he's alcoholic, ma'am, and the patient, he used to eat high meat products, and I used SGA tool, ma'am, for screening. When the patient was
Hello?
no, ma'am. Hello.
Dr. Martin, can you hear her?
Yeah.
I think she got disconnected. Let's give a second.
Yeah, the close to.
Go ahead, Madhvi.
Ma'am, my voice is audible?
Yes, you are audible. I think Dr. Martin dropped.
Yeah, ma'am. I used SGA tool, ma'am, and the patient protein intake was inconsistent, and fat intake varied depending on preparation. And my patient is middle class patient, ma'am.
Okay. And what was the kind of diet that you advised during the discharge?
Bland diet, ma'am. For 1 week only,
Yeah.
I suggested bland diet, ma'am. Why? Because the patient is not that much stable. But we till 1 week we suggest the patients to go with the soft food, like khichdis, dalia, or some like that, ma'am.
Okay.
And we tell them to avoid high fatty foods and high oily foods also, ma'am. Including in vegetable curries also, don't use high oil. Just to go with the low salt, low spices. Better to give in bland or boiling way.
Yeah.
We tell like that, ma'am.
Yeah, that's fine. My advice to you would be, next time when you're doing a presentation, try and have like a comparison. What was the kind of diet followed initially, and what is it that you advised later? All right.
Yeah, ma'am.
Anyway,
Thank you,
good
ma'am.
work.
Next time I will do, ma'am.
Yeah,
Actually,
that's
some
fine.
slides are missing, ma'am.
Okay.
It's not coming.
Yeah, that's fine. That's fine. Thank
Yeah,
you.
ma'am. Thank you, ma'am.
No worries. It happens, but you've managed it very well, Madhvi.
Thank you, ma'am.
Okay,
Madhvi,
good.
I have a question. What was your initial height and weight for the patient?
Yeah, ma'am. My patient height was 167 centimeters, ma'am, and weight is 76, ma'am.
Okay. So how much of proteins did you give her?
Actually, it is 76 gram, ma'am.
Okay. So it was how much, around 1.2 or
1, ma'am, only kg per 1 gram per kg, ma'am.
okay. Fine. Yeah. Okay. Thank you. Thank you, Madhvi.
Thank you, ma'am.
Mhm. Okay, so we will move on to our next presenter. Good job, Madhvi.
Thank you,
Um,
ma'am. Next
mhm.
time I will do better, ma'am.
Yes, yes, we all learn. There are learning opportunities, and this is exactly what it is. We just learn
Thank you.
from, our experiences and our seniors. And you'll have multiple opportunities in life to do this, and you'll look back and think,
Yeah,
okay?
ma'am. Thank you,
All
ma'am.
right.
Thank you.
Yes, yes, no worries at all. Okay. So the next presenter is Isha Chakrabarti. Isha, are you here?
Yes, ma'am. Good afternoon.
Okay. Sai, is Isha's presentation ready to share? Okay.
Shall I go ahead?
Yeah, please, your time starts now. 10 minutes and
Uh,
try to fix to your time limit, and then we'll have questions.
Thank you. Sure.
Mhm.
Good afternoon to all my respected senior dietitians and my colleagues. I'm really thankful that I got this opportunity. So my name is Isha. I'm from Manipal Hospital, Bangalore. My case study presentation is on post-liver transplant challenges and its management. So I have done my case study presentation. Next slide, please. Next slide, please. Yes. So I have done my case study presentation on a pediatric patient. So my patient is 1 year, 9 months old baby. She is a female baby. And initially she was doing well. Her birth weight was 3.4 kg. But 3 months after her birth, when her mother noticed there are certain changes in her, they are from Mauritius. Initially, they consulted our doctor over there. Then they finally decided to visit India and go for the further treatment. So, in the month of March 2025, when she was diagnosed with polycystic liver disease, so basically, polycystic liver disease is a condition when the formation or the flow of bile can be disrupted. So it could be due to intrahepatic or extrahepatic. There can be reasons. So intrahepatic reasons like hepatobiliary infections can be one of the reasons. Sometimes drugs or diseases like hepatitis, HIV, autoimmune conditions, and extrahepatic conditions are like gallstone, cyst, and many other conditions are like that. So for her, when I checked with doctor, it's like autoimmune due to autoimmune, and treatment plan was transplantation. So she has undergone all liver transplantation in the month of September, 19 September 2025. Next slide, please. Okay, so my patient is actually currently her body weight is 6.6 kg. She is non-vegetarian. She does not have any kind of any food allergy, but she is a picky eater. So it might take another 1 or 2 months for her to get discharged. She's still in the hospital. There are certain concerns after a liver transplantations like poor weight gain, total weight thrombosis, persistent hydrogen output, lymphatic leakage, AKI, dyselectrolytemia, and hypoalbuminemia. But thankfully, most of the concerns are either resolved or getting resolved. And our goals are meet the target calorie and protein value gradually, gradual weight gain, resolve the lymphatic leakage issue through MCT based diet, and overall improvement. Next slide, please. So as we can see, this is the biochemical parameters which are within the normal range. Even the ascites drain output is also have markedly decreased and all. And I have collected the data of a week, and these are the data of December month. So currently her parameters are much more better than these parameters. So initially, even though electrolytes are within the normal range, initially we have observed she has to go through very frequent corrections, But nowadays she is maintaining all her parameters within the normal range without much of the corrections. Albumin currently within the normal range, and drain output is like 50 to 75 ml for 24 hours. That also we are hoping will be resolved very soon. Next slide, please. So this is the medication chart. So these are some of the important medications which play crucial role after liver transplantation, immunosuppression to avoid graft versus post disease. Steroid, very importantly, playing the same role as like a immunosuppressive agent. And peptide drug, as patient is on steroids to control the sugar level sometimes. And peptide, another thing that what peptide helps to specifically target the drug delivery. That also it actually helps to do multivitamins, because magnesium and all, as we can see the McGowan, so magnesium, vitamin D, those are really very low, but nowadays all her parameters, as I have said, within the normal range, and antibody. Next slide, please. Yes, the nutrition intervention. So patient is on neutropenic, high calorie, high protein, MCT based diet, semi-elemental formula, albumin based formula, semi-MCT oil. These are the things which have been used. And for water intake, we followed pediatric water requirement formula and physician advice as well. Next slide, please. So, nutrition intervention. So, which I have tried to do. So, I have tried to make a table in the tabular form. I have tried to project how I have planned the diet and what was our target calorie value, how much was achieved, and how what is the span of time where we have achieved all the requirements and all. And one more thing that I would like to add, so there is a conflict in between regarding her drain output, whether it is a chylus leakage or due to chylus leakage or due to portal vein thrombosis, the drain output is happening. So patient has undergone for lymphadenopathy. Before that, patient was on MCT based diet and other form of fat were really very less. So 80% of total fat was coming from MCT based fat, and 20% of fat, which is basically some chicken breast or liver fish, whatever we have suggested for the patient, that was coming from the non-MCT based fat. So this is the nutrition intervention in detailed manner. So the target value, we have very low target value just to avoid syndrome, because phosphorus was really very low. It was like always used to range in between 1 to 1.65. So that's the reason we don't want repeating syndrome to happen. So we want 65 to 60 to 65 kilocalorie per ideal body weight, where the 40 to 45% was achieved, and 50 to 1.2 gram per ideal body weight was the target protein value. In that, 50 to 55% of target value was achieved. She was consistently having hyponatremia, so 2 grams of salt sachets were added. Week 2, all other criteria remain same, where along with salt or potassium rich diet, we focused on potassium exclusively, and we educated the mother, and we have changed also in diet pattern, like some of the millet based item, more of green leafy vegetables, banana, tender coconut water, all those things we have. Especially, I educated the mother to add all those things, and I made sure she's providing all such kind of things. So in week 3, gradually I have increased the target calorie and protein value. In that, 60 to 65% of target value was achieved, and 80 to 85% of protein value was achieved. The reason behind the protein value was really increased because I have added albumin based formula. As I have said, this patient is a picky eater, and she was not liking egg white in form of like anything, like whether it is boiled egg white or some kind of poach and all. So I just discussed with doctor, and we go ahead with albumin based formula. She really liked it, and we really got a very good result. Week 4, the criteria remain same. Week 5, I have again increased the target calorie and protein value, and in that, 70 to 75% of the target calorie value and the 60 to 65% of protein value was achieved. So calorie value was really increased because I have increased the doses of MCT oil. And week 6, 95 to 100%, like totally 100% of calorie value was the target value. In that, 90 to 95% of calorie and protein value was achieved, because along with oral, we have started with TPN, because doctor was like not so happy. He wanted it to happen 100% and all. That's the reason we have started with TPN. And the reason behind TPN, because it's a liver transplantation case, and sometimes she was having some acidity and some other abdominal discomfort problems. So that's the reason, instead of TP, enteral feed, we chose for the TPN chart. Next slide, please. So this is the detailed TPN chart. How much? What is the rate of infusion? Amino when 10%, lipid 20%, DNS 10%, and multivitamin 5 ml was going on. So total volume was 382 ml, and total calorie was 180 kilocalorie per day was achieved from TPN, and the amino acid 6 gram per day was achieving from TPN, and the remaining was coming from the oral diet. Next slide, please. Yeah, so the conclusion part. So positive weight gain by 20% within a span of last 20 days that happened. Albumin level is improved, electrolytes are persistently in normal range, and magnesium, phosphorus, thankfully now in normal range. Even vitamin D is also improved. Intake has been improved because we have done a lot of changes in her diet. Like sometimes every after 10 days or 12 days, I have to change the diet plan because she is really a picky eater. So like some vegetable tikki and all, and wherever I can do the changes and all, some kind of soup or grilled fish or grilled chicken, those are the things I used to educate her mother. But thankfully, when doctor allowed her for other form of fats, then I have gradually added many of other options as well. And the chyle leakage has been reduced by 65% and able to achieve the target calorie and protein value within a span of 45 days. Thank you so much.
Thank you so much, Isha, for that presentation. And you stick to the time. That's wonderful. All right, so let's see if any of our jury members have any questions.
I must say it is one of the, the best as of now after Sarika's presentation. I've heard of it, and every minute detail she has covered.
Right.
So yes, so it is actually, yeah. So congrats, Isha. It was very, 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 very well done. Okay, so I
Thank you
just
so much. It means a lot, ma'am.
it's really very nice, and I just see, because I come from a hospital background. How did you plan the TPN part? Is it with the connection with the doctor? Do you have a separate PIVA room, or how is it?
One second. Ma'am,
Yeah,
if you don't mind, can you repeat them once
yeah.
again?
Do you have a separate PIVA room, or where was preparation of the TPN which was done?
No, ma'am, it's bedside. The sisters are handling it is bedside. Basically, what we are doing, doctors, it is basically it's getting done by the doctor. So they are maintaining the TPN chart. If anything is getting missed, like any particular time it is getting missed and all that, we are checking with sisters. If sometimes NP or something like that, that we are following, but predominantly it is getting decided by the doctors and sisters are handling. And what we are following, if anytime it is getting missed or something like that, that particular documentation that we are trying to keep with us.
Because TPN for a pediatric
Yes.
is very, very challenging.
Right.
Very
At least
challenging.
it is
Very
very, very
challenging.
easy. So it is like
Very
you just have
challenging.
a bag.
Yeah.
Either it's a
Yes.
3-chambered or 2-chambered
Yeah.
bags we
Yes.
have,
Yes,
and we
ma'am.
just hang
Yeah.
it. So, but the thing
And
is for
actually, yeah.
pediatric
Actually, in
nutrition,
our yeah.
every
Mm-hmm.
step,
Yes, ma'am.
especially the baby is very small. 1 year,
Very
9 months,
very
it's
small.
hardly,
Very small.
it's a
Small.
tiny one.
Yeah.
So it is
Yes,
very,
ma'am.
very
Yes, ma'am.
interesting to understand.
Yeah. Yes, ma'am.
Yeah, because in our hospitals we
Oh.
have a separate fever room where the
Okay.
mixing is being done and taken care of. So
Yes.
it
Yes,
was
ma'am.
my question to you to understand
Yes,
how was it
I
gone.
understood. Yes. Yes, ma'am. So
Otherwise, I
that's the
have
reason I
nothing
have
to ask.
chosen a pediatric case because nowadays these pediatric like this age group they are really getting affected with so much of complicated cases. Like I have patients 11 years old with CKD. Stage 2 hypertension leads to CKD and also that's why I felt I should go for a pediatric case. It's challenging, but there are a lot to learn. So this is the
True,
thing.
very, very, very true, Isha. Very well done.
Thank you.
Yeah.
Thank you.
Over to Mathima.
Yeah. Just one question. Were you doing the
Yes, ma'am.
calorie calculation regularly, Isha?
Yes, ma'am. So basically, as it's a pediatric case, one more thing I wanted to say when I was presenting, ma'am, I mentioned for ideal body weight. Usually for underweight patient, we try to go for actual body weight. She's having ascites as well, so and we are
Right.
keeping a record of her body weight on daily basis. It's a
Right.
very different parameter. Very
Correct.
187, 7.5, and we
Yes.
don't know the adjusted body weight. Also, we are not
Yeah.
understanding what to do. Then I checked with doctor. Doctor also told ki you blindly follow the RDA part. So as we know, for 1 to 3 years old baby, it is 12.9 kg that I have taken. And for 1110 is the recommended calorie as per the RDA. So 1100 to 1200 I'm keeping the calorie cut, because too much also could be a problem for a children. We cannot make it as like 1400 1500 kilocalories. She
Right.
won't be able to tolerate.
Mhm.
And the second thing is 1.2 we started with the protein, and doctor told we can go up to 30 gram per kg body weight, which is coming like nearly 2 to 2.5. So based on the ideal body weight I consider and go for all the
So you were
calculations.
regularly calculating and
Yes,
making the
ma'am.
changes
Yes,
accordingly.
ma'am.
Good,
Yes, ma'am.
good.
Yes, ma'am.
Yeah.
Like as I told, sometimes when it is magnesium or phosphorus, these are the things when the drain output, still
Right.
she needs to be in hospital for another 2 months.
Yeah. All right. Good job. Thank you.
Yeah, thank you.
Very good presentation, Isha.
Thank you so much, ma'am. It means a lot.
Yep. Mm-hmm. Our last presenter today is Muskan Fatima. Are you here? Muskan? Muskan? Are you on mute talking?
Yeah, good evening, ma'am. This is
Okay.
Muskan Fatima, dietitian at Mallareddy Narayana Multi-Speciality Hospital. So today my case study on
Share the screen, Sai.
yeah,
And
yeah,
you have 10 minutes,
yeah, ma'am.
Muskan, and then you'll have few questions from the jury members. Your time starts now.
Okay, ma'am. My case study is on post left knee amputation with uncontrolled diabetics mellitus. Next. Okay. First, the amputation definition is amputation is a surgical or accidental removal of a body part, most commonly a limb, arm, leg, hand, or foot. So, my patient age is 45 years, height 167 centimeters, weight 65 kgs. Coming to the BMI 23.3 kg. Condition is left knee amputation. Comorbidities of patient is type 2 diabetic mellitus. So my focus is on medical and nutritional management. Next slide. So I can take a case study, a 45 years old male patient with uncontrolled diabetes mellitus and a left knee amputation due to diabetic complications. Poor glycemic control increased the risk of infection and delayed wound healing. This case study emphasizes medical and nutritional interventions to support recovery and glycemic control. So the main causes of amputation is diabetic neuropathy, loss of sensation, unnoticed injuries, peripheral vascular diseases, foot ulcers, severe infections, poor wound healing. Diagnostics of amputation is clinical examination, blood test, neuropathy test, vascular assessment. The final one is infection evaluation. Medical profile and interventions are long-standing uncontrolled diabetes. Next slide. Here. Long-standing uncontrolled diabetes, post-operative knee amputation, insulin or oral hypoglycemics, antibiotics and pain management, regular blood glucose monitoring, wound and physiotherapy. Next slide, please. The goal sign nutritional assessments are problems of a patient's poor glycemic control, increased protein requirement, risk of infection. Our goal is to control the blood glucose, muscle loss, and improve nutritional status. Next slide. The medical and nutrition therapies. Give low glycemic index carbohydrates. Of course, we all know that glycemic index means measure of how fast your food rises blood sugars like glucose. Low glycemic index foods contain 0 to 55. In this, the grains, pulses are included. Medium glycemic index foods are brown rice. The medium glycemic index values are 56 to 69, and the high glycemic values are 70 plus. In this, white bread goes the white food items are comes under. So high biological value protein. High biological value protein means how easily protein digested and well absorbed by the food and gives essential amino acids. And the moderate fat intake also give high fiber diet. Next slide. 1 day sample diet plan. Early morning, I will give methi seeds, water plus almonds. In the breakfast, I suggest vegetable oats upma plus curd plus 2 boiled eggs. In mid morning, I will give Goa. Lunch, brown rice, dal, soya bean curry, mixed veg curry, and salad. Snacks, roasted chana plus green tea. Dinner, chapati, rajma curry. By the end, bedtime, turmeric milk. Next slide. The dietary intake of a patient approximate the intake is carbs 280 grams, protein 78 grams, fat 37 grams, and the energy is 1675 kilocalories. The conclusion is structured medical nutrition therapy is essential for optimizing glycemic control and accelerating wound healing. When integrated with medical care, it significantly improves recovery outcomes for patients post amputation. Thank you.
That was a very short and crisp presentation, Ms. Khan.
Yeah.
Do any of you have any questions?
Yeah. Hello,
During
Muskan.
Yeah, ma'am.
Yeah. So I just wanted to know that you mentioned that sample diet plan. In
Yeah.
that, you have not mentioned the quantity, you have just written the food items.
Yeah.
So actually, you need to mention the quantity also. No?
Yeah, ma'am. Yeah, ma'am. Sure. Next time. Yeah, ma'am.
And second thing is like, how did you arrive at 1675 kilocalories? Like, how did you arrive at that figure?
Yeah, ma'am. By the help of RDA, I can calculate the energies, ma'am, because the patient is diabetic. So
Okay.
with the help of ideal body weight, I will give with a 25 into
Okay.
65 into 25 per kg weight. It's come under 1375.
Okay.
1675.
1675. Yeah. And I wanted to know, like, you have not mentioned, like, means, did you use any supplements or you did not use any supplements?
Yeah, ma'am. Yeah, ma'am. Patient was diabetic and the case is amputation. So we should give low calories and high protein and high fiber diet. Yeah. I used the ONS. Yeah, ma'am.
But you have not mentioned which supplements. You have not mentioned that you have used a supplement, like.
Okay. Yeah.
Your presentation.
Yeah.
Yeah. Thank
Yeah.
you.
Next. Yeah, ma'am. Next.
Sure. Yeah.
Next. I will try my level best.
Yeah, sure.
Anyone else have any questions for Ms. Khan?
I had the same query, so she's already asked it. So I'm good.
Okay. All right. Ms. Ananya, do you have any questions?
No, not really. Yeah, not really.
All right. I think that marks end of our presentations for today. Thank you everybody for attending this webinar. that has been sponsored by Pulse, where we are trying to do the case studies from different parts of India. A lot of young dietitians are coming forward and doing these presentations. And I also would like to give a big shout out to all our jury members for taking time out from their busy schedules and coming and helping these young dietitians understand, how the process works and how to do the presentations and everything from your experience. Thank you so much on behalf of Nutri Health Foundation. And we will meet in another case study presentations next month. Thanks, everybody. Have a good rest of your day.
Thank you, Deepti. Thank you.